So I've separated my title into wide volume CT and low dose and ultra low dose CT. So there'll be aspects of wide volume, there'll be aspects of low dose and ultra low dose, which can be separate from wide volume, and then there's the combination of the two. And I'm really going to focus on more of a practical way of what we're actually doing and why we're doing it. I was just talking to some of you outside and earlier during the days is that sometimes it's nice to reiterate certain themes because when you don't have the 320, the concept of what you do with the 320 becomes a little bit sort of in the future. But when you get close to having a 320, you kind of think, well, maybe we'll do that. Then when you've got one, it'd be nice to think, well, if they're doing that, what about us? Why aren't we doing that? So some of the themes will be very similar. The other thing I want to take up on is something that Russell mentioned about grainy images and acceptance of new techniques. I've moved away from asking my colleagues about what they think about image quality. I've moved more towards, do you think this is diagnostic? Because when you ask about image quality, it means different things to different people. But if you say, is this a diagnostic image? And then they say, well, what do you mean? And you say, well, what are you looking for? And they say, well, nodules. I say, well, can you see the nodule? And they say, well, yes. So thank you. And so I would say to you that if you're going to try to go to low dose or ultra low dose, be careful what you wish for. Be careful what you ask, and ask the question to which you want the answer. Is this a diagnostic scan? And going to Larry's viewpoint about the tipping point between risk-benefit, it's really not about image quality. It's about what's the diagnostic utility of the test, and I think that's what you're getting towards. So have a think about that as we talk. I do get research grant from Toshiba Medical Systems. Doesn't go into my pocket. I don't have a bank account in Panama. It goes to fund my PhD students. So what I'm going to do very practically, I'm going to go through the what are we talking about when we're talking about standard dose, low dose, ultra low dose, and I emphasize that this is for filtered back projection. So the paradigms are shifting, as you've heard from the talks earlier, particularly Russell's talk. I'm going to talk about what do we talk about wide volume, and this will be very quick because you already know about that. Why should we think about doing low dose, ultra low dose? Why should we think about doing wide volume CT? And the three S's are the safety, speed, and specialization, and we'll talk about that. Who benefits from these techniques? Where in the thoracic cavity would we apply these techniques? And as we talk about this, I want you to think about your practice, what you currently do, and whether you could adopt some of these techniques. When is the right time to start doing this? Okay, and how do you do it, right? Anyway, so very quickly, I'm going to go through very quickly. I do a lot of phantom work to proof of concept. So if I turn on the X-ray tube and one of my colleagues will put a device measuring the beam before it goes to the patient, we look at the ionization. If we measure the amount of energy deposited in the tissues, that's the absorbed dose. If we look at the tissue sensitivity of the absorbed dose, that gives us the equivalent dose. And of course, as Larry mentioned, if you try to compare different areas of the body with different types of ionization, you can do the effective dose. So going back to what do we mean by standard dose, low dose, ultra low dose, one of the most important parameters here is what you as technologists do. So before I did this audit, my idea of our standard dose chest was 3.5 millisieverts, low dose was 1 millisievert, ultra low dose was 0.2. But of course, it's really difficult to get the apices of the lung plus 1 millimeter, and it's very difficult to get the costophrenic angles plus 1 millimeter. So whether you go from the vertex to the pubic symphysis for a chest CT, I've never seen that, it will change the effective dose, right? So the most important people in this room, in terms of radiation dose, are you as technologists, right? So no matter what protocol I put in. So this is why when I did our audit of the last year, our standard dose is 3.9, because it does vary. Our low dose filtered back projection is 1.3, and our ultra low dose is 0.2 millisieverts. And this is the same patient. It was a trial we were doing, and you can see actually, if you look at image quality, it's actually pretty good, even at the 0.2. But one thing I'll bring your attention to is the apices, and I always go on about this. If you want to look at how good a technique is for the lungs, look at the apices. That's where a lot of photons are absorbed, and that's where you see some image degradation. The second part is at the bases of the lungs, where X-rays are being absorbed from the liver and the spleen, okay? Everybody will show you around the carina where there's very little X-ray absorption. That's not where you want to look at. So that's just one piece of advice. So Larry mentioned this as well. Low dose standard dose and ultra low dose are per patient. So if you've got somebody who weighs 300 kilograms, their low dose technique for the chest may be, I don't know, 8 millisieverts. That's still low dose for them. Okay, so just be aware of, we're trying to move away from cookie cutter to individualized protocols, and there's certainly ways of doing this. So you know about wide volume we've gone, and Larry did a really nice show of how we've gone from single, dual, the LSINT 64 row to 320. And why have we gone that way? Well, there's some really good things about wide volume CT, and there is some challenges too, right? On the left, that's the striker for Newcastle. On the right, that's Man United, just in case you're wondering. So that's soccer for you guys from North America. So why wide volume CT? And what's really quite unique about the Aquilian series? Well, wide volume allows you to cover a particular area much, much quicker. And so Russell and I are aligned on our hearts in the heart. And so it's really revolutionized the way we do cardiac CT. But the unique thing about the Toshiba scanner is that all the elements are the same size, 0.5 millimeters. So you get the same spatial resolution everywhere in that picture. So it's isotropic, isometric. You get isophasic imaging, mean every little point of that acquisition is at the same point in time. And if you're doing contrast-enhanced CT, it becomes really important. Also becomes important when you're thinking about perfusion and functional imaging. Overbeaming is something that is more of an issue in helical scanning. And the way I like to think about this, if you look at the bottom picture, there's a torch or a flashlight. And if it's night and you shine it, you see the main beam, and then you have a little halo around the main beam. Well, that halo exists also in CT. So when you have the detector, the X-ray tube, it has the main beam, and then it has this little penumbra around it. And as you spiral around the patient, that penumbra doesn't actually give you any useful information, but it gives you extra radiation. So we don't see that so much with the wide volume. And the second thing, sorry, I just showed you, when we've done this phantom work, I have to acknowledge my colleague Hatim Meres, who's our CT physicist from Toshiba, did a lot of this work. You can see that the CT dose index is on the vertical axis and increasing collimation on the horizontal axis. And you can see that if you use the same exposure parameters, same sort of rotation speed, that if you go with a 4-detector configuration, the CTDI is quite high, and this is mainly due to overbeaming. But as you start to go to the 20, the 40-detector configuration, the dose per rotation comes down. And in fact, the 80-row configuration, which just happens to be the prime, is quite a nice optimal sweet spot between rotation speed and radiation dose and image quality. So that's because of overbeaming. And with a wide volume CT, we don't have that so much. And we also have less issue with overranging, which is before you start the acquisition, the tube has to rotate a certain distance, and at the end of an acquisition, it rotates a certain distance, and it gives X-ray radiation to the tissue. But I think, as Larry mentioned in his talk, if we can just activate the movie here, with electronic collimation, you can get asymmetric collimators coming in. So at the start of the rotation, the collimator will come into the side that you don't need the radiation, and it will reduce the irradiation to the bit you don't need. So for example, if you're doing a chest, the collimator will come in at the start on the neck side, and you reduce the radiation to the thyroid. You get uniform coverage then, and then as you go to the abdomen, the other collimator will come in and reduce the radiation dose to the upper abdomen. So the electronic collimation has been really important in reducing that. One of the issues with wide volume CT is the subject of scatter. So scatter is in every X-ray tube, and what happens is you get the X-ray tube, you get the X-ray tube, you get a patient, and depending on the size of the patient, you'll have various amounts of interactions where these X-ray photons will ricochet off the internal structure, and then many of them will go straight through to the detector, but several will kind of bounce around to other parts. If your collimation is quite narrow, you're not going to pick up much of this scattered radiation. But as the collimation increases, you pick up more of the scattered radiation, right? So that becomes a potential issue for wide volume CT. But we've shown you some phantom work. This is a humanoid phantom from Kyoto Kagagu, which is a really lovely handmade piece of kit. And they take a long time. They're very expensive because they are handmade. The only thing is they're the size of an adult male Japanese. As most of you know, if you've seen these, they're about the size of an 8-year-old American boy. So we have to give them extra padding to make them look like the North American sort of client. Anyway, we've planted a ground glass nodule in this, and this is low-dose CT with filter back projection, 20-row collimation versus 80-row. And you may not see too much on the slides, but there is a little bit of, as Russell put it, what do you say, graininess? Graininess? Okay. There is some graininess, and if you actually go to adaptive iterative dose reduction, you can actually see that the iterative reconstruction does clean up the image really very nicely. And let me exaggerate it by going to the ultra-low dose so it may see it more clearly. Here you have the ultra-low dose 20-row configuration filtered back projection, and you have the 80-row ultra-low dose filtered back projection. Both are very noisy images. Both of these you wouldn't really want to report. I would argue that this is more noisy than this due to scatter, but it may not show on PowerPoint. But again, if you do the iterative dose reduction, you can see how well the features are cleaned up and preserved. And so the iterative dose reduction does improve image quality at low dose and ultra low dose, and it corrects on a large scale for that sort of scatter. It doesn't take it away, it corrects for it. And this is what I'm going to show you. We have some images on FIRST. I will say that our FIRST, now that we know that it's clinically approved, we can actually use it more freely than we have done in the past. And it does clean up the images on even regular dose, but on a humanoid phantom, it's kind of tough to really appreciate. So let's go to the ultra-low dose. And you can see that if you just did filter back projection, you'd very much lose this ground glass opacity. Adaptive iterative dose reduction cleans it up further. And I'm hoping you can appreciate that on FIRST, the whole image is fairly homogeneous, it's very sharp, and much more pleasing to the eye. So I'm going to show you some clinical pictures. These studies were not done on the Genesis, so we don't have the advantage of the pure vision and the optics. And our anticipation and the experience from Russell is that they'll be even better than this. But so here's some coronal images, a regular dose, 2 millimeter reconstructions coronal. You can see on filter back projection that the the emphysematous lung is seen reasonably well, but look how much it pops with the latest model-based iterative reconstruction. So even on regular dose, FIRST does extremely well. Let's take a more challenging case, regular dose, 0.5 millimeter coronals with apical fibrosing alveolitis. And you can see how you've got this image degradation through the upper tissues. You can see the features for sure, but I think you'd be happier to report the septal thickening and reticulation. It's not an issue in this patient because it's so drastic, but what if the only part of disease was really in the apex of the lung? Then you may have a bit of an issue. And this is a patient I always like to show because it's the most extreme case you can get. It's an ultra-low dose, 0.2 millisieverts. It's ultra-thin, 0.5 millimeters. The patient is not small. In the north of England, we call this cuddly. And but you know, cuddly doesn't give you a diagnosis, right? You're having a look and saying, well, is there anything here? And in fact, you would have missed, most of us would have missed that apical lung cancer. So these are just some initial images to show that with this model-based, there's some real promise. As Russell had pointed out, with the successive generations of the wide volume, particularly cardiac CT, we've seen our doses go down and our image quality go up. And comparing we have an experience of almost 30,000 cardiac CTs now. We did a lot on the Aquilion 64, then the Aquilion 1, and the Vision, and we anticipate the Genesis. About half of our CTAs for cardiac now are less than a millisievert, and our population is not small. And that's a very significant advantage with the wide volume CT. The other advantage that people don't think of so much is the speed. We compared our experience with 64 slice to 320. And even in our department where we have radiographers really good at doing cardiac CT, we prepare the patients really well, do IV beta blockers and all the rest of it, and we prepare their breathing. About 4% of patients will breathe during that CT acquisition with a 64 helical, particularly if you're doing prospective scanning, right? About 4%. With the 320, I've never seen motion artifact in our coronary arteries. I don't know if you've seen them. It is so quick that even if the patient kind of hiccups, everything moves at the same sort of rate. And so as long as it's in that volume, you don't miss it. So that's been a huge advantage for us. And I think it's something that's understated. Having that volume allows us to get some functionality now. And this is something we started way back in the early 2000s in terms of tracheal imaging. Now you might say, well, why do you want to image the trachea? We see a lot of patients who have breathing issues, but they're not asthmatic, their heart's normal, and they don't have emphysema. And some of those patients have tracheobronchial malacia, where the windpipe collapses when they're trying to breathe. And it's kind of like going to one of these fast food restaurants and suck up a really thick milkshake through a collapsible straw, right? And that's kind of what happens to them. So what we do is we take the 16 centimeters and we go from the clavicles to the first bronchial bifurcation. We ask the patient to take a deep breath in, and then we ask them to breathe out as fast as they can. And we take several reconstructions, about 5 rotations, 0.5 seconds each, and we reconstruct at we can see the whole trachea, but just for illustration, I've shown you at the thoracic inlet, the arch, the carina, and the bronchi, and see what happens as the patient breathes out. So we will look at these in cine format, and you can see at the onset of the breathing out, you can see there's a lot of motion, but then you can see the collapse of the trachea all the way down to the major bronchi. Word of warning, if you're athletic enough, you can do this normally without having tracheobronchial malacia. It really depends on how hard you want to try. So the patients have to have symptoms, okay? We've done a lot of this, and I'm going to show you one case where it made a big difference. Our thoracic surgeons love this. If your thoracic surgeons do not believe in doing any operative procedure for tracheobronchial malacia, it's kind of almost pointless doing this, apart from making the diagnosis. But our patients are operated on. So for us, the wide volume CT transforms CT imaging, not only in the heart, but also in the lungs, from structure to function to physiological assessment. And I think that if you've got these kind of machines, which you've paid a fair amount of money for, that you want to start thinking about going beyond the anatomical structural thing, because you can do that with most CT scanners. You can do that with all CT scanners. You've really got to think about what's the value add that this equipment does. So who benefits from having this ultra-low dose, and particularly the wide volume? Well, in fact, it's all ages. But in particular, the ages that are susceptible and vulnerable. So we don't have a pediatric population where I am, but where I'm moving to in London, we do have pediatrics. And we've seen from a lot of pediatric hospitals, being able to cover the whole chest, for example, in one rotation, allows them to move from GA cases to light sedation to maybe no sedation on their children. We also have a lot of patients, as we all do, have patients who are ambulatory and we have patients who are not ambulatory. And they're sick, and they breathe, and they don't hold their breath very well. So having speed, fast coverage, wide volume coverage allows us to get better images from these patients. The other thing is having, for example, in cardiac, having the ability to do the scan very quickly also allows us to reduce the contrast we give, not just the radiation dose, but the amount of contrast we give to these patients. And remember, all of these patients that I've shown you here are going to get repeated scans. The kids that have CTs tend to have CTs throughout their lives. The ICU patients and the sick patients will have. So it's not just the one visit you have to think about, it's the accumulated radiation dose. So wide volume CT, in my opinion, is useful for all patients, but is specifically valuable for the vulnerable in our society. So where are we using this now? So this is our clinical routine for the following. We've been doing lung nodule follow-ups for ever since the early 2000s, leukemia and bone marrow transplants, the mid-2000s. We just started bronchiectasis, a lot of lung transplant patients, and as I mentioned, the tracheomalacia. It's not really the disease types, it's really what are we looking for. We're looking for nodules, nodule follow-up. We're looking for pneumonia. We're looking for bronchiectasis. So these are the kind of things that you're going to see even in a general practice. So the lung nodules, I'm going to talk to you about a study we did, because you can say, well, yeah, that's fine, but does it make a difference to patients? So we did a 5-year study where we took patients, 271 patients, who had curative surgery for lung cancer. 8 of them were stage 1. We did what we called at the time minimum dose CT, because that's the lowest we could go. Now clearly we can go lower, so it was minimal for the time. We've done over 1,100 matched pairs, chest X-ray versus ultra-low dose CT. 52% of those patients had no disease at the end of 5 years. 25% of those patients had recurrence or suspected cancer, and another 23% had definite recurrence. And if you look at the algorithm of the patients who had new or recurrent cancer, of those, 22% were symptomatic, and all the ones that were symptomatic needed palliation, and their survival was about just over a year. Of the ones that were asymptomatic, only the CT, the ultra-low dose CT, performed at similar dose to the chest X-ray. Only the CT picked these up, and that was 49 patients. of whom 12 had palliative treatment, but they lasted almost twice as long as the patients who were symptomatic. But the bigger group were the 39 patients who were asymptomatic and were curative treatment. They all underwent another resection, and their survival is about 69 months, so almost 7 years. So this is the first study that I know of that's compared ultra-low dose prospectively in a population and showed it made a difference to this patient population. So it's not just about saving radiation dose, it's also changing what happens to that patient. I will say, though, this was not a prospective randomized trial, okay? So we have to be limited in our interpretation. But here's a patient, just to show you what sort of quality of scans you could get. Now remember, this is filtered back projection. This is not with first or iterative reconstruction. See these visceral nodules here? These all were cancers. And you can see them just as well on the 3.5 millisieverts. But note, this is not at the apex, this is not at the lung base, okay? This is around about the carina. So a lot of promise. In the mid-2000s, we started doing low dose instead of chest X-ray in our leukemia patients. Leukemia patients with neutropenia and sepsis, they're a very vulnerable population. They do not, when they get a fever, you don't know where the source is. Is it in the chest? Is it in the abdomen? And we used to do chest X-rays, complete waste of time. So we've done a trial that showed that low-dose CT picks up more disease, picks it up earlier, and you can start the appropriate therapy sooner than later. So this is now part of our clinical routine at Princess Margaret Hospital. And it's not just leukemia patients. Patients who are on chemotherapy for breast, who are neutropenic and fever, they all get this CT. Our latest trial is on patients with atypical mycobacterial infection, and you have all of these. These are everywhere, right? These usually mid-age. Now, of course, the older you get, middle-age definition changes, but between 45 and 65, shall we say, and they have indolent disease. And we're doing a trial now where our routine is low dose, but we're also matching them with an ultra-low dose CT. Now, these images were taken off the Vision, second generation, so that, again, they don't have the advanced optics that the Genesis has. But I just want to show you, so in filtered back projection, you have the bronchiectasis, you have the nodules, the cavitations, and the bronchial wall thickening. When you reduce the dose to 0.2 millisieverts, you can still see the features. But if you look at the first image at 0.2 millisieverts, I think you would agree that the image quality starts to become more comparable to the higher dose filtered back projection image. And in fact, all of the features that you'd want to see in bronchiectasis, you can certainly see in the ultra-low dose first. But one thing I want to draw your attention to, if you look at the coronal images at the bottom, yes, the 1 millisievert filtered back projection shows you the features, but look at the quality. You can see the image degradation through the shoulders, and it's clean. And one thing I think that Russell showed you was that the homogeneity of the image on the model base is way superior to our other reconstructions, and that's something that's really very striking. And just a few other cases that maybe make this more clear. You can see on the right at the apex here, the 0.2 filtered back projection you wouldn't really want to report. This is really very, very nice. And if you look at the coronal image here, you can see the bronchial tree are much better even than you see on the first. So I think there's a lot of promise, and even for for fairly early bronchiectasis, you can see on this whole coronal that this is really a very nice homogeneous image with very fine detail. So I think I'm not surprised that Russell's using this routinely in his scanner. Again, I'm sure on the Genesis these pictures will be even better. So we have just started tipping our toes in the water on looking at 1024 reconstructions. I just thought I'd show you a couple of images from comparing these cases, both done with first, a 512 reconstruction and a 1024 reconstruction. I don't know how long this took. Hatim did this offline, so you can ask him how long it took. And I'm not sure how well it projects, but if you look at the first image, which is really very nice, on the 512 you can see the interlobular septa going right to the pleura. But if you look at the fissure here, which is a little bit thickened, you can see some undulation here. Whereas on the 1024 image, you can see it's way smoother. And you can see a similar sort of thing with this example here. When you look at the airway, the wall of the airway, little irregular here, a lot smoother here. So the question you're going to ask is, which is truth, right? And that's why we're doing our phantom work, to say, well, does the first 1024 improve it, which theoretically it should, or does it actually smooth it? So this is something that we're going to be doing with our phantom work. But I think the initial feedback that we've had is actually that people prefer the 1024. As I am in the musculoskeletal section, for some bizarre reason, I thought I'd show you a bone. There are bones in the thorax, so I guess I'm there. Here's the first 512. And I think you could agree, I hope you agree, that if you look at the vertebral body, you look at the trabeculation, and you even look at the basilovertebral vein, it actually pops. It really is very, very nicely seen. But I would like to emphasize the most important part of the thorax is what's inside the pleura, not what's outside it. And so I mentioned to you about the lung transplantation, the inspiratory, expiratory. I will emphasize to you that I actually think dynamic imaging is the way forward. So doing this static InSpin-X I think it's okay, but I think moving forward we need to find ways of doing the dynamic acquisition, and this is where Russell mentioned that with the wide volume detector, how we're going to do it. I've told you about the tracheomalacia. I'm going to share with you, if you just activate this movie, just going to share with you this case about 2 weeks ago. A young man with Morquio syndrome, so he's got a connective tissue disorder, and he had some issues post-operative, and you can see as we go down, we're asking him to breathe in and out. You can see that trachea takes a right angle turn, and it becomes very, very narrow. Now this gentleman stands about 2 feet tall, and he had been seen at, play it again please, he'd been seen at Sick Kids for some years, and when I saw this, when I saw his regular chest CT, I was worried about his trachea, so we came in and with this dynamic, again, take a breath in and breathe out. We did this, and we went back through his records at Sick Kids. They said, yeah, he'd had some difficulties post-op. Well, if you look at his trachea, it goes at right angle above the carina. Now remember, if you're having a major surgery and you're being ventilated, the end of the ET tube has to be below the obstruction, otherwise you're not being ventilated. So we had a major issue. Unfortunately, I haven't got the 3D volume. As you could see, the trachea takes a shift. It goes slit-like, and then it comes back. And so they had a combined operation with the thoracic surgeons, the vascular surgeons, and the neurosurgeons. It was a 10-hour operation to correct this. Because there was a worry that you could correct his spinal deformity, but he couldn't breathe, which is never a good thing. So these kind of techniques do show you things that you've not seen before, okay? Lastly, I'm going to talk about perfusion, and I'm very grateful to Dr. Schmidt for introducing iodine maps. And I've said for the longest time we've done, inverted commas, perfusion with pre- and post-contrast studies. Iodine maps, you now have a talk from an expert. You can do these with different KVs. You can do these with different MAs, and this is the role that we prefer. But my view is that image subtraction, iodine maps are a step on the road to dynamic perfusion. And the reason is, I think it'll give us more physiological information. So the idea is you inject the contrast and you take multiple ultra-low-dose CTs sequentially through the area. And you can see the way the contrast flows from the blood into the tissues, into the capillaries, and into the interstitial space. And it allows us to do lots of different things. So if you play this movie, this is just a pig model that we're doing with an inflatable balloon in the right lower pulmonary artery. And you can see in the right lower lobe that there's a difference in terms of the perfusion. And you can see it's doesn't happen straight away. It happens over time, okay? And we're doing a lot of work. We've done about 30 pigs, and we're just starting a trial with patients who've got chronic thromboembolic pulmonary artery hypertension to do dynamic scanning. Now, these were juvenile pigs, which are 20 kilos, so you can get the whole chest in a 320 detector. It's not so easy when they're a few weeks older. And we put regions of interest all through the lungs, so we look at the time density curve to see how that contrast comes up and down. And then we can chart on the vertical axis, we can chart the way the blood flow goes, the mean transit time for blood, the time to peak contrast, the peak contrast uptake, blood volume, and the blood volume under the area of the curve at different inflations of the balloon, so different degrees of obstruction. And one thing we've noticed is that blood flow, mean transit time, and time to peak, and the peak contrast start to change about 70% occlusion of the pulmonary artery. But it's interesting that the blood volume itself, in our experiments, starts to change only at 90%. So there is some thought that the blood volume is the most significant parameter for tissue viability. So going back to what Dr. Schmidt was showing us, if you did the iodine map, you may see it positive in terms of defect at a very early stage of obstruction, depending on what you're looking at. But if we're talking about tissue viability, I think we need to tease out some more parameters. So this is still work in progress. We're still trying to figure out a lot of things. The more I do of this, the more I learn, and the more I realize we don't know. But I think this is really exciting. And this is the kind of work that will take CT from anatomical to functional to perfusion imaging. So in summary, we've talked about dose, and these standard dose, low dose, and ultra low dose for filter back projection. We talked about wide volume CT. You've got to think about why would you do low dose, ultra low dose, and why would you use a wide volume? And for me, it's all about safety. It's about speed of image acquisition and about specialization. I think all our patients benefit, and certainly in our practice they benefit, but particularly our vulnerable population, I think, benefit proportionately more. I really think that if you've got one of these scanners, you should really look at your practice and see what you should be doing in your areas. Again, if you're following up lung nodules, if you're looking at patients who've got pneumonia and are vulnerable, if you've got MAI, you shouldn't be doing full dose CTs for those, because the features you're looking for can be seen certainly on low dose, and if you've got first, you could go ultra low dose. If you haven't got lung transplantation, it's not an issue. And again, if you've got patients who've got unexplained breathlessness, think about doing the tracheomalacia study. And I think the future is very bright for lung. I think perfusion and dynamic imaging for lung and heart is the way to go. And with that, I thank you very much.